My name is Kasia, and I'm a consultant oncologist, and I'm also an MR-Linac specialist at Genesis Care. So today I'd like to give you an overview on evidence and some practical considerations in reirradiation for gastrointestinal as well as hepatobiliary malignancies. And I'll start with a case presentation. This is a 65-year-old male patient who presented with an early low rectal cancer back in 2019, and he underwent a laparoscopic anterior resection with histology summarized above. Unfortunately, in 2020, he was found to have an extraluminal recurrence, shown here on the PET scan and MRI scan with no distant metastasis. He received neoadjuvant conventionally fractionated chemoradiotherapy, achieving a complete and radiological response. And at that point, exenterative surgery was discussed, which he declined, and completed adjuvant chemotherapy and went on to imaging surveillance. Unfortunately, he subsequently developed a further extraluminal soft tissue recurrence. He was offered systemic therapy at that stage, which he completed with minor response/stable disease, and he was referred for a surgical opinion. He again declined surgery following consultation with 2 independent pelvic surgeons. And here I listed a range of factors which may influence decision-making when considering treatment options for pelvic recurrence, which may include the tumor molecular phenotype, the volume and resectability of recurrent disease, and most importantly, the chance of receiving an R0 resection margin, which in series have been consistently associated with improved outcomes. In addition, patient preferences are to be taken into consideration, but the discussion must include a discussion about potential risks should the chosen local therapy fail to control pelvic disease, as we know that uncontrolled pelvic disease can have a significant impact on quality of life and patient outcomes. So pelvic saber reirradiation is currently a commissioned treatment option in the UK in patients with recurrent pelvic disease. Real-world outcomes from the CTE program showed good but short-term local control rates, as well as acceptable toxicity rates. However, locally recurrent rectal cancer and gynecological cancers were underrepresented in the CTE program, and data from small series suggest that low-dose saber has a relatively low local control rate in this setting, with most patients in this particular series unfortunately passing from uncontrolled local disease. So there's certainly an unmet gap in care in this setting. And to address these gaps, as well as significant variability in treatment provision, the UK Saber Consortium and ITTQA have developed a national pelvic saber reirradiation protocol to standardize practice in the UK. And this protocol does acknowledge an unmet need in patients with locally recurrent rectal cancer, and it permits an isotoxic dose escalation, which means escalating the radiotherapy dose until the organ at risk constraints are met. So Dan already has covered this, as well as general dosimetric considerations in saber reirradiation in detail. But in the setting of pelvic recurrences, it may be important to mention that although generally organ at risk constraints would always be prioritized over PTV coverage, this may not apply to locally recurrent rectal tumors, which are involving or infiltrating the lumbosacral plexus, in which case the GTV and PTV coverage may need to be prioritized over lumbosacral plexus sparing, and this has been accounted for in the DS&AL organ at risk constraints published in 2022. So MR-guided saber lends itself very well to a setting of pelvic reirradiation, and that has been summarized very nicely by Dan. So it provides us an opportunity to escalate the dose beyond the standard reirradiation dose of 30 gray in 5 fractions. And this is possible through the reduction in uncertainty margins on the MR-guided platform, reduced dose to the organs at risk. In addition, that allows the patients to then recommence their systemic or targeted treatment as they have less side effects, so usually within 2-3 weeks of completion of saber, and there may be some biological properties such as lymphocyte sparing that might confer some further benefit in this setting. So, this is actually a summary image that demonstrates how mobile a rectal, so in this case, this is primary rectal cancer, but the mobility of targets in the pelvis, and how through use of daily adaptive radiotherapy, we can account for this interfractional variation in anatomical position in targets and optimize the treatment plan accordingly. In addition to prevent or minimize the risk of geographical miss, we can also reduce the dose to mobile organs at risk. And here, for example, in this case, you can see a loop of small bowel entering the high dose region. So if we treated this patient with the original plan from day one, we would have overdosed the small bowel loop. So coming back to our patient, he did go on to have a MR-guided SABR to the para-anastomotic recurrence, and there's a screenshot of the plan. Given that his original chemoradiotherapy dose was quite high, with a simultaneous boost up to 53 gray, we were only, even with isotoxic dose escalation and not adhering to the lumbosacral plexus constraints, cumulative constraints, we were only able to deliver 35 gray and 5 fractions. We delivered this plan using daily plan adaptation to account for variability in rectal filling, trying to spare as much of the normal rectum. Despite this, he did develop a grade 2 diarrhea, which required a short break in treatment, but he was able to complete the treatment successfully with supportive medication. And here you can see that even though this is an extraluminal recurrence, we still had to adapt the plan daily depending on the rectal filling that and we did that both to spare and preserve the normal rectum, but also to account for positional variability in the target, given that was influenced by the rectal filling as well. So this is his diagnostic MRI pelvis at 6 weeks post-treatment, does show a good partial treatment response, and repeat MRI has been requested for a 12-week assessment. So I'm moving on to a second case just to illustrate the benefit of MR-guided radiotherapy further. A young patient who initially received TNT for a upper rectal cancer, followed by anterior resection and adjuvant chemotherapy. And again, he then about 18 months post-treatment developed an extraluminal recurrence, a small lymph node, 1.5 centimeters soft tissue nodule. He wasn't prepared to consider further surgery, and he was treated with MR-guided radiotherapy with isotoxic dose escalation to 45 gray and 5 fractions. He was actually treated on the NHS in Oxford and on the compassionate access program. And I've seen him recently in clinic. He's now 2 years exactly out from the reirradiation, and he continues to do well with no evidence of disease recurrence, and he suffers from moderate Lars syndrome, but this is quite well controlled with supportive therapy. So moving on to liver SABR reirradiation, again, just based on a case we've treated with 2 courses of MR-guided liver SABR. This is a patient with metastatic colorectal cancer who initially developed metachronous liver metastasis. He had a 2-stage ALPS procedure and then recurred with 3 liver metastasis. He had microwave ablation to a segment 3 lesion, and then MR-guided SABR to the remaining 2 right lobe to the remaining 2 remnant liver metastasis in 2020, and then he had a repeat SABR to marginal recurrence. So you can see these are the 2 courses of MR-guided SABR that this patient underwent. So the evidence for SABR reirradiation to liver metastasis and primary liver tumors is quite scarce. I mean, there's a number of mainly single institution series, and these are mainly in patients with primary liver tumors, hepatocellular carcinoma, treating with either proton therapy or CyberKnife, or conventional Linac standard Saber. There's one series here in patients with metastatic liver disease, and these patients were treated on the same platform, the ViewRay platform, using MR-guided re-Saber with similar constraints that we apply to our patients. And then this series, the 1-year overall survival and progression-free survival were good, although as we would expect in this cohort of patients, we saw a relatively high rate of intrahepatic progression, out of field progression. So good local control, but high rate of further development of further liver metastasis. The treatment on the MR-Linac was well tolerated without any grade 3 or higher toxicity, and the authors summarized the dosimetry and the reirradiation protocol, which is very similar to the protocol that we use. So the two parameters are important for cumulative organ at-risk constraint calculation is the mean liver dose and also the volume of the liver spared. So either from 15 gray, or if we're more conservative, spared from a dose of 13 gray. And in terms of the mean liver dose, that parameter will be different for patients with liver metastasis and HCC. Generally, for patients with liver metastasis, we would accept a dose of a mean liver dose of 15.2 gray. And again, this is from the Diaz and al. publication. For patients with hepatocellular carcinoma, the cumulative mean liver dose is around 13 gray. And that has been associated in series with maintenance of the Child-Pugh score. So we have audited, I mean, this slide is courtesy of Elena. We at Genesis Care have audited our outcomes for re-Saber in metastatic oligometastatic liver disease. And we included patients who had received 2 or more courses of Saber, and patients who had a CPS score better than B7, and a minimum prescribed dose of 30 gray and 5 fractions for re-Saber. We used the approach to tolerate cumulative organ at-risk tolerances that was explained by Dan, and we used the deformable image registration to approximate the liver volume from the 2 courses. And we did a central review of the response to the initial course of Saber and then re-Saber, and we looked at our outcomes. So here I've just have got an illustrative slide which illustrates how MR-guided liver Saber gives us much higher confidence in treating liver targets than conventional CT-based Saber, both in terms of soft tissue definition, as well as, I don't know if this video will play, as well as real-time target tracking and beam gating. So you can see that we've got a boundary, and as when the target moves in within this boundary, the beam switches on. When the target moves out of the boundary during respiration, the beam will automatically switch off, and that allows us to apply very small 3 millimeter margins on the target. And this is this summary of our workflow. I'll skip through that in the interest of time, but you can see here on an example that this was the patient with the first course of Saber and then the second course of Saber. In this case, this was a marginal recurrence, so you can see the targets are very close to each other. And we use a deformable image registration fusion, which again is easier with MR-guided Saber. We apply dose accumulation, and then we're able to accurately report healthy liver dose. So in terms of the patient and treatment characteristics, we audited 12 patients who are treated with 18 lesions treated, range of age, but generally young patients, equal spread between males and females, and predominant histology was colorectal. You can see that for the first course of Saber, we were able to, the majority of patients received 50 gray and 5 fractions, so standard dose of SABR to liver metastasis. A very large proportion of these patients had prior surgery or liver-directed therapies, and the median interval, similar to the Gemelli study, between the courses of SABR was around 16 months. And as you can see, actually, for the second course of SABR, also able to deliver a very good ablative dose of radiotherapy with a median dose of 45 gray, range between 30 and 55. But 5 out of 12 patients, so nearly half of the patients, were able to receive a second course of 50 gray and 5 fractions, which is a BED of 10 of around 100. And the typical fractionation was 5 fractions. And there was half of the patients received type 1 and half type 2 reirradiation. And you can see here the geometrical distribution of the SABR targets, as well as, just a reminder how we define type 1 and type 2 reirradiation. And again, a summary of the dosimetric parameters for the primary and the secondary course of reirradiation, good dose delivered for both courses, a range of GTV volumes, actually, in some instances, treating quite sizable targets. And we were able to achieve a good mean liver dose. So this is really quite low, with even the upper range of the cumulative mean liver dose being within a very acceptable range, and a good amount of liver spared. So in terms of our results, we had one patient who relapsed with in-field disease, but otherwise all the other patients had local control at a median time of 10 months, with a range to 33 months, and we haven't observed any grade 2 or higher toxicity, with quite a lot of grade 1 toxicity. Most commonly, this is fatigue, but also often there's some nausea following liver SABR. We had one patient who had delayed grade 4 colohepatic fistula. That was a patient who underwent 2 courses of SABR to the marginal target, quite close to the bowel, and in series from Japan, from Jastro. This has been associated with high rates of complications, and 1 year overall survival in this cohort of 71%. So just very quickly, they're my last 2 slides, just to touch on one further indication for abdominal re-SABR. So this is a patient who had a Whipple's procedure for pancreatic cancer. He then recurred in the pancreatic bed, had a sort of high-dose palliative radiotherapy course 25 and 5, had stable disease 6 months afterwards, but worsening celiac plexus pain. And he reached out to us to see whether we can offer him some further radiotherapy. Given that he had no disease elsewhere, and this was a single site of disease, we felt that he would have better local control and symptomatic control with a higher dose of radiotherapy. And again, he was treated to 35 brain, 5 fractions with an isotoxic dose approach. This is an extract from his plan and dose distribution. And we looked at the literature search at that stage. We identified one single institution series who of re-SABR in pancreas cancer, and the local control rates of this treatment were reasonably good, with overall disease control about 86%. This is, I think, only at sort of 6 to 12 months perhaps, but good symptomatic control. So 75% of patients had pain relief, and none of these patients experienced severe gastrointestinal toxicity. So in conclusion, I would say that pelvic and abdominal SABR reirradiation can be considered in selected patients, especially patients who are not candidates for salvage surgery, and obviously that always has to be considered in the first instance. MR-guided radiotherapy might provide a dosimetric advantage in the setting of reirradiation, and we need prospective data collection, including PROM data, to standardize practice and allow a more widespread implementation and delivery of this treatment. And I'm just put my email address here in case there are any further questions. And thank you to all the collaborators. Thanks.